So next, we'll have the introduction of the African Society Presidential Address by Darshan Reddy.
Good morning again, and thank you for this opportunity to tell you a little bit about the president of the African Society, Professor Frank Edwin. So I'm gonna show you a side of Frank that most of us haven't seen before, and a little bit of background. He graduated from the University of Ghana Medical School in 1994, and I'm sure many of you don't know this, he obtained a diploma in anesthesia before starting in general surgery residency. Dr. Edwin started his cardiothoracic training in 2002, and this is a picture of him during his cardiothoracic surgery residency with a surgeon from Nigeria. Frank was made the chief cardiothoracic resident in 2004 and completed his residency the same year. In 2007, Frank became one of the founding members of the World Society for Pediatric and Congenital Heart Surgery, and this was at the historic inaugural meeting held in Washington, D.C. This is something that we often hear Christo and the rest of our colleagues talking about, and Frank was there. He met Rob Kinsley during the Washington meeting in 2007, and during this meeting, Rob presented his vision for training of African pediatric heart surgeons. And obviously communication developed from there, and Frank subsequently joined Rob in the Walter Sisulu Pediatric Cardiac Center for Africa. This was in 2009, and this was based in Johannesburg. So this is a picture of Frank with Rob and Johan Brink, who I believe now works in New Zealand with Kirsten. This is a picture taken outside their office at Sunninghill. And I'm sure many of the surgeons in this room have visited Rob's hospital and the Walter Sisulu Center over the many meetings that Rob's had. This is a picture of Frank with his wife Ama and Rob with Tia, who again, I'm sure many of you that have visited South Africa will recognize Tia. At the first fundraising dinner of the Walter Sisulu Pediatric Cardiac Center. This is just a picture of Frank working in the operating room with Rob. And for those of you that know Rob very well, he loves this kind of interaction with patients who've had surgery, following up with them. And I think this is where Frank has developed his compassion and caring approach to patient care from Rob. Jeff Harrisburg is one of the cardiologists at the Walter Sisulu Institute, and again, many of you may have met him over the years, and this is his interaction with Frank. And finally, Frank's farewell and send-off in 2011, August. Ironically, this is the year that I met Rob. So at the end of Frank's tenure with Rob was where I met him. Frank subsequently went on to work in Ghana, and he's been a consultant cardiothoracic surgeon at the Ghana National Cardiothoracic Center since 2004, and the Ho Teaching Hospital since 2017. The main focus of his work is pediatric and congenital heart surgery since he returned from South Africa. Between August 2013 and August 2015, Frank served as a visiting associate professor to the School of Applied Science at the Central University College, and in November 2016, he was appointed the visiting scholar to the Department of Surgery at the University of Health and Allied Sciences. And in January of 2017, as if all of that wasn't enough, Frank was appointed professor of surgery and then dean of the School of Medicine at the same university. With regard to his World Society activities, it never ceases to amaze me how Frank makes time for this society, and we are certainly very grateful for every minute of it. He was appointed to the Governing Council in 2014, subsequently appointed as secretary in 2018, and I don't see that role ending anytime soon. Executive Committee in 2018, He's been involved with the World Journal on the editorial board since 2018 and has been the associate chair of the World University since 2020. He's also participates in the Journal Watch Committee of the World University. And just some pictures of Frank's interactions with some of the colleagues in the room. This was at the Kyoto Symposium in 2015 with Bob Anderson and Drissi, and a subsequent meeting at Abu Dhabi in 2016 at the Governing Council meeting. What never ceases to amaze me is Frank's prolific writing. And I did a quick search, and these were just articles that were published in our journal, which is the World Journal. And I've left out all the other articles that Frank has authored. And what's absolutely amazing to me is that for every type of article published in the World Journal, Frank is a first author. Whether it's a review article, a case report, expert technique, invited commentary, as well as the proceeding articles. And this is just a testament to Frank's ability to be committed to this cause, both from an academic and from a clinical perspective. A little bit of the history of where the African Society started. Christo's mentioned the Orlando meeting, and this is a picture that was taken at that meeting in Orlando in 2018, where we had the initial discussions about should there be a society in Africa, and Frank was pivotal to this discussion. So in this picture you can see Adele, Marcello, Christo, Frank and myself. And this is where the beginnings of this idea of an African society came about. And so I would say that Frank, as part of this initial group, I think you were the natural leader for us. And Frank also has a family that we keep him away from. And as I mentioned, he's married to Amma, who's a physician clinical psychologist and a bioethicist, and they have 2 sons and live in Tema, Ghana. So with this last slide of Frank's beautiful family, I'd like to welcome the first president of the African Society, my friend and colleague, Frank Edwin.
Thank you very much, Darshan, for that introduction. And a very good morning to all of you. I consider it a great honor to stand before you today as president of the African Society to deliver this address in keeping with the established traditions of all the assemblies of this kind in our profession. I would like to begin by expressing my gratitude to the many people who have made it possible for me to stand here today. Darshan just spoke about my family. They've had to endure many absences and Zoom calls just because of what I do, and they've supported me in everything that I do. I'm very grateful for that. I wish they were here today, but I'm sure that time will come. I pay special tribute also to the executive committee of the African Society, particularly our executive director, Christo, whose vision and energy and continuing support have been instrumental in the birth and growth of this society. I thank our 2 vice presidents, Drissi and Darshan, our secretary, Suzanne, who is unable to be here today, but I'm sure has joined us online, our treasurer, Adele El Gamal, who has no cash flow to manage. I know it's an uphill task that we've taken on, but it's been a privilege working with all of you guys. I'm sure we are going to do good as we continue. I also want to thank the local organizing committee, Drissi and his team. I suspect I've probably left out a few names, but I thank all of you for the work that you've done hosting us and making us proud as well. There are very many people in the World Society who've also helped the African Society in our journey so far. Our past presidents, Marcello, Zohair, Giovanni, the team from the World Database, Dr. Kirkling, Jim St. Louis, they've helped us a great deal. The World University team, Claudia Hebbs and Adam Becker, Christo and Dr. Kirkling are in there again. Very key members, Dr. Jeff Jacobs, Marshall Jacobs, Nestor Sandoval. Many people have supported us and have brought us this far, and we are very grateful for all their contributions. I move on now to two of my living heroes, people who have contributed a great deal to my journey. Professor Kwabena Frimpong, the one you see on the screen, is a cardiac surgeon, Ghanaian, who inspired my journey in cardiothoracic surgery. He trained under Professor Bost in Hanover and returned to Ghana in 1985 to set up Ghana's National Cardiothoracic Center. He essentially trained almost all the cardiothoracic surgeons in the country. The very first one who was trained is here today, Dr. Sribo. Lawrence, are you here? Okay, thank you. Thank you for coming. Yes, so he has been a great inspiration for us in Ghana. He's trained not only Ghanaians, there are several people from Nigeria who've come to Ghana to train as well. And a lot of that is because of his sacrifice in coming down to Ghana to help us. My story would not be complete without mentioning Rob Kingsley, who is widely regarded by many of us as the father of pediatric and congenital heart surgery in Africa. In my welcome address yesterday, I mentioned the influential role Rob has played in my own career. His generosity towards me would fill a book, but there's no time to tell that story here, except to re-echo the point I made yesterday, that this meeting is rightly dedicated to him. So this being the first presidential address of our society, I thought I should dwell on issues relating to our vision and what I consider to be the first steps going forward. Several cardiac societies exist in Africa, and so some have questioned whether there's a need for another one. For example, there is PASCA, which is the Pan-African Society of Cardiology. There is PASCATS, which is Pan-African Society for Cardiothoracic Surgery. There's a AATCVS, which is the African Association of Thoracic and Cardiovascular Surgeons. And there are a few others. If you ask me, my answer to that would be definitely yes, we need another association like that. And the principal reason is that there is no African association that represents the interests of children with congenital heart disease on the continent. Neither is there any association that cares for the people who provide care for these patients. There are a few other issues too. It has to do with whether some of the problems that we face on the continents are addressed by current guidelines. What you are looking at on the screen is the MR of a 6-year-old child with tetralogy of Fallot. This child had developed several cerebral abscesses. And the question you ask is, where in the world would you have to watch helplessly children with tetralogy develop such lesions, undergo multiple craniotomies, and simply because their parents cannot afford the cost of treatment? Or where would you see a patient like this, a 10-year-old with rheumatic heart disease and cardiac cachexia, whose parents can't afford the transportation to bring him to hospital? What do the guidelines say about people like this who are everyday cases in Africa? And these are some of the few reasons that I believe make the case for our society. Darshan already told you about how the society started. This was the picture Darshan showed you already. During the Orlando meeting, we had these discussions during one of the coffee breaks, and these are the people who started that conversation. This picture is actually the very moment when that decision was taken, that definitely we need to talk about, we need to form an association for that society. But at the time, it was just an interesting idea. We just thought, well, we'll have to do it sometime. This may not be the right time, but we definitely have to follow it up. But then the following year, COVID hit the world. And it drove all societies online onto the Zoom platform. And suddenly what looked like something that was an interesting idea was suddenly within reach, because now all the potential members of the society could be reached on Zoom. And so, again, we must give credit to Christo. He was the main driving force that started all the negotiations and the Zoom calls that started it. So this was, I think, one of the first Zoom calls we had forming the society. It was a town hall meeting on Zoom. And you see the key people there. Claudia is there, Christo is there, James and Louis, Darshan, I see Suzanne there. Dr. Kirkland was there in that meeting as well. So that is how we started this society. So we called it the African Society for Pediatric and Congenital Heart Surgery. And our continental representation follows the AU designation with the inclusion of people in the diaspora, sorry. So our members are Africans, but they do not necessarily work in Africa. Neither do they necessarily have African ancestry. Some are black, some white, and some in between. So someone asked me, what is African about this society? It seems anybody can just join it. So the question I say is, it's not about ancestry, it's not about where you work, it's about the disposition that you have. And from here, I would say, I'm Christian, but I'm not Jewish. Neither was I born in Israel. But I'm Christian because I choose to identify with the spirit and mission of Christ. I'm also African. I happen to be born in Africa. But just like the first president of Ghana said, I'm not African because I was born in Africa. I'm African because Africa was born in me. So I'll say anybody with this kind of disposition who has a deep connection to the continent of Africa, interested in the welfare of his people, who is dedicated to providing care for children with heart disease, is welcome to be a member of our society and to help us fulfill our vision. That vision is that every child born anywhere in Africa with congenital or acquired heart disease should have access to high quality medical and surgical care. To accomplish that vision, we have set ourselves on the mission to promote the highest quality cardiac care to all patients with pediatric and congenital heart disease, with a focus on excellence in education, research, and community service. We are not only focused on surgeons, as I said earlier, on anybody who has an interest in providing care for children with heart disease is welcome. But if you look at our vision and our mission, it is focused principally on access. Access. We say we want to promote access. So what is access? From our viewpoint as practitioners, we usually understand access as encompassing 4 dimensions: service availability, affordability, reasonable distance to care, and cultural acceptability. And we would interpret that to mean that there is the provision of timely and accurate diagnosis, timely treatment with excellent outcomes, complete follow-up. But what about our patients? How do they see access? How do the patients and their parents view access? They don't know about 4 dimensions. They only know about the patient experience. And how do they experience the access that we aspire to promote? To one such parent, access was being the 23-year-old woman who was pregnant out of wedlock and living in the slums of the city, who delivered a female neonate and was discharged home, apparently well baby. And then that baby, after 3 to 6 months, develops paroxysms of breathlessness and irritability, and then goes to the nearby clinic and was told this is only a case of asthma. Then somewhere along the line at age 6 months, he gets told this could probably be heart disease and an echo is requested. That baby is put on a 3-month waiting list for the echo, but at age 9 months, he develops a stroke. That forces an echo to be done at 9 months, that diagnoses tetralogy of Fallot, but the mother has no funds to afford the recommended surgery. He's discharged home at age 10 months, to raise funds for a BT shunt, which would cost $2,500 in my country. He spends a year raising that fund, comes for the BT shunt, waits another 3 years to raise funds for total repair. And then at the end of it all, he realizes that this child is damaged with neurological deficit. This is the child coming for follow-up. This is 3 years after total repair. And the mother is asking, will she become a nurse? When she was born, My dream for her was to become a nurse. But she has difficulty studying in school now. Now, you see that child, you see the attitude of the left upper limb. It's a hemiplegic posture you see there. That's her CT scan. You are the doctor. What do you tell this mother? She's going to be a nurse. That's the same patient. Now, if you were to ask this mother to tell you what access is, she's not going to talk about 4 dimensions. She's going to say, access is no child being sent home from the newborn nursery without a diagnosis of an important congenital heart defect when it is present. She's going to say no child has to wait for emergency congenital heart disease intervention when it is needed. She's going to say no child has to wait for more than a month for an elective intervention of CHD. She's going to say there ought to be prepaid funding available for all children with congenital heart disease, and that no parent has to be financially crippled trying to provide care for their child who is affected by congenital heart disease. That is access to her. It is tangible, it is palpable. When it is not there, it is clear. Yesterday, we heard the story of another patient, tetralogy of Fallot, same lesion, totally different outcomes. And you ask yourself, we say we are promoting access as the African society. That is the idea of the task that we have taken on as a society. Unfortunately, this patient experience I've narrated is not the isolated one. This table that you see there is based on a 2013 estimates that we did and published. And it shows you there are roughly 300,000 children born in Africa with congenital heart disease every year. If you use the worldwide incidence of 8 per 1,000, you can tell where these children are born. Interestingly, you see that roughly half of them are born in only 7 countries. 7 out of the 54 countries in Africa are responsible for 51% of the burden of congenital heart disease. Nigeria, Ethiopia, DRC, Egypt, Tanzania, Uganda, and Kenya. Of these countries, Egypt is the only one that has a good kind of system to address these lesions. The remaining 6 do not have that much. And this is the task that we have taken on. In Ghana, we know that the survival of these children without treatment is just about 28% after 5 years. We know in the developed world, the current survival rate is about 95% of those who are born with congenital heart disease. Why is it that this is the case in Africa? Several authors have worked on this. They've proposed reasons for that. You can see that on the slide. Inadequate number of facilities equipped to provide congenital heart disease care, inadequate skilled manpower, regressive health care financing. Most of the patients have to pay out of pocket. Most African countries do not have insurance to address these problems. No newborn screening programs for detection of critical congenital heart disease at birth. Poor primary health care facility, pervasive health illiteracy, inadequate local research output for data-driven decision-making. These are all reasons that we know quite well. The next few slides will depict some of the evidence for that. So this is data I extracted just at the beginning of this month, and it shows you the number of congenital heart surgeons that are registered on the CTSNet website. You see that there's a total of 284 surgeons, 20 countries out of the 54. More than half of that number is in Egypt alone. There are many countries there that don't have any at all. This is not exactly accurate because there are some people who have not registered, but it just gives you an idea. This is the best evidence we have so far of this. And so when Jimson Lewis was talking about his database and some of the research that we need to do, it is very clear that we need a system to find out who is where, how many are they, what kind of system are they running on the continent. Without knowing that, our task is going to be really insurmountable. Again, this is information that was published in 2014. It's probably old. Some changes might have happened, but again, you have an idea of where the facilities are when you look at that, the number of open heart procedures that take place on the continent. This is a map that shows you countries that have recommended, they have legal systems for newborn screening. And as you can see, no country in Africa has got a legislative means and have recommended newborn screening for critical congenital heart defects on the continent. This is something we need to seriously work on. Research, we talk about research. So again, one of the things I did was to look at the Scopus website and see what is Africa's contribution to congenital heart disease research in the world. And the map you see there gives you an idea. So if you use congenital heart disease as the keyword in the Scopus database, you see between 1940 and 2022, over 94,000 papers that have been published, 1,860 from Africa. These are papers with authors affiliated to countries in Africa. And you see the contribution is just 2%. 2% of the contribution from Africa. So I thought, well, maybe it's because it's too broad. So what about if we looked at our own journal, because it is the only journal that is dedicated to the practice of pediatric and congenital heart surgery. And again, you see from the time of inception of our journal, April 2010 till April 2022, over 1,500 papers published, only 46 come from us. Just 3%. These are not pretty figures, but I think it's important that we know, so we know where we are starting from. In 10 years, we should be telling a different story. We should make serious efforts at research. So far, it appears that we are focused on just service, but without doing the necessary research, we really are going to have a very difficult task making any change at all in promoting the access that we aspire to do. So Africa has fallen behind. That again is no news, and these are many of the reasons. We've already talked about them. The question you ask yourself is, why is it so? All the reasons that I've spoken about are contributory, but to me, the most fundamental reason is the fact that there is a very low political priority for children's heart disease in Africa. So the question you ask is, what is political priority? And these are some of the questions that have been posed to try to address that issue. Why do some global health initiatives receive priority from international and national political leaders, whereas others are ignored? I mean, there are policies and funding for things like neglected tropical disease, some of which have actually been eradicated. And yet there is funding every year in countries in Africa for those diseases. And the only reason is because they are embedded in the national health plans of these countries. What will make governments pay attention to the issue of children's heart disease in Africa? We haven't addressed that. What will make policymakers consider children's heart disease to be worthy of sustained action and back up that action with the provision of financial, human, and technical resources commensurate with the severity of the problem? Sometimes you get governments say, okay, you go ahead, we'll give you this, we'll give you that, but the support they are providing is actually not commensurate with the degree of the severity of the problems we are dealing with. So the question we ask ourselves is, what would bring about a change in the situation? So political priority actually is an issue. For an issue, defines the degree of attention given by political leaders to the issue, their commitment to providing resources that match the severity of the issue, and their enactment of national policies to address that issue. Now, for me, the key thing is whether these policies are embedded in the national health plans, because that is actually what determines where resources go in the countries. If you are not on that plan, you don't get much. If your name is there, you get resources. You have resources for cataract surgery, you have resources for trachoma, and the reason is that they are embedded in the national health plans of African countries. We don't get anything for congenital heart disease because we don't have any organized advocacy to get them embedded in the national health plans of our countries. Now, this is a study that was done 2016, and it looked at 43 independent African countries, and this is what I was talking about. So you find that in all these countries, there are defined targets for the control of HIV, tuberculosis, and malaria. There is funding for these diseases. There are control programs for them. If you look at the 43 national health plans that the study looked at, only one of them mentioned cardiac surgery. never mind congenital heart surgery. But 100% of the policies publish disease prevalence for HIV. 95% had got prevalence data for TB and malaria. There is nothing on congenital heart disease or children's heart disease. So it is clear we are not going to get any funding from governments unless we find ourselves in the national health plans of our countries. So how is it that we don't get any mention at all? How is it that we are not there in the national health plans? And I think the reason, as I said, is because there's very little organized advocacy effort towards doing that. Most of the control programs that you find have got very strong advocacy groups pushing for these things. We have not organized ourselves to do that. And I think that is one of the main reasons why the society is very, very necessary. But to be able to do that, we have to build a very strong society. Without building that strong society, our advocacy efforts are not going to amount to much. And so in trying to do that, we have identified some strategic priorities for the African society, which we are going to try and work on going forward. So first, we want to look at membership growth. Then we'll address effective governance. We'll look at education, research, financial sustainability, advocacy training, and inclusivity. I mean, most of us are surgeons. We are preoccupied with technical matters. We don't do too well with advocacy. But where we find ourselves now, we need to get involved in advocacy. We can't just keep ourselves in the OR and leave it for the governments to do something about it. They will not act. Unless we push them, they will not act. So this is how I propose we go about it. So look at recruitment, engagement, and retention of membership. For governance, we have our constitution to consider. Monday, we have a meeting. We are going to consider that. We need to have policies and procedures for accomplishing things. We need to address our dues and partnerships that can help us become financially sustainable. We need to address advocacy, communication, and global reach. We have to talk to patients and their families. We need to organize civil society. We need to talk to governments and NGOs, the press and the media. We need to get all these groups involved in order to get advocacy going. Education is something we are very particular about, and the World University is very helpful for that. We are going to form advocacy. We are going to form groups that are going to address research. I just showed you the data on research. Inclusivity, I talked about that earlier on, that you don't have to be just working in Africa. Just a short while before this meeting, a colleague was asking me, I'm not African, I don't work on the continent, I work in Canada, but can I join the group? Definitely, these are people who are very keen to support. Anyone who is keen to support us, you are really welcome to join us. So in conclusion, I'll say that our problems are system-wide problems. They go beyond technical expertise and the OR. It's a public health problem, and we must position it as such. Political priority is fundamental to what we need to do, and the time has come for us to work to secure that, because we know that until we do that, all our exploits in the OR will not amount to much. I admonish all our members to rise up to this challenge and use whatever resource you have at your disposal for the treatment of children's heart disease in Africa. I thank you.